Okay, should we make a start for this session? Good afternoon. I'm going to introduce the speakers for the session, which has been put together for traumatic lumbopelvic dissociation. So we thought it would be good to have something completely different to what we've discussed over the years. And I was going to say lower the tone of the meeting, not lower the tone of the meeting, when we get our pelvic colleagues involved, because we do see a lot of patients with polytrauma who've got pelvic and spine issues, and we do work in tandem with them. So it's nice to have pelvic surgeons come along to share experiences so that we can learn from them. So I'll introduce the three speakers that we have. So first up is Amol Chitre. He's a consultant based in Preston. He's the major trauma lead in Preston, and he looks after the Preston region and has been a consultant for nearly 9 years. Next to him is Nikhil Shah. Nikhil Shah is based in Wrightington. He does all complex hip arthroplasty and does pelviacetabular reconstructions, so it'll be great to have their input. And we've got Alex Montgomery. Alex is one of our colleagues based in Royal London, who will give the spine perspective for things. So we'll make a start. So Amol, can I invite you to come and give your talk, please?
Right, so thank you for the kind invite to come in to speak at BritSpine. I think it's probably the first and only time I will make an appearance here. As Session has said, I'm a consultant at Preston, essentially a trauma consultant, and also work at Wrightington within the North West Pelvic and Acetabular Reconstruction Service. No relevant disclosures to this. And in terms of the aims of this presentation, I'm going to talk a little bit about what is a spinopelvic dissociation. I think my remit was the initial assessment, and really to talk about emergent problems, the emergency stuff that might come about when we're dealing with it. So the first thing to say is there's very little evidence out there. So when I first got asked to do this talk, as you do, you sort of look things up on PubMed, and I typed in lumbopelvic dissociation, and you get 46 results. So I thought, hang on, I know this is spinopelvic dissociation, let's type that in. And you get 94 results. So there's not very much there. So to put this into context, cervical myelopathy, which I think is the session that follows, has 25,000 publications. And we've got 150 that we're going to be thinking about. So then you look at systematic review. So this is a fairly recent systematic review from 2021. And it talks about 50 studies. 19 of which were case reports, 16 of which are said to be low-level evidence, and overall only 380 patients within all of those 50 studies. So not a lot of evidence out there as to what we're doing with these injuries. So most of them are a result of high-energy injuries. And I will put a little rider on that, in that we're now seeing an increased prevalence of elderly patients who have very similar type injuries from very low energy trauma. And that may be a problem that we have to contend with a bit more in the future. But in terms of the incidence of these type of injuries, they're 2 to 3% of all pelvic ring injuries. And in a standard average major trauma centre, we'll see maybe 100 pelvic trauma cases a year. So we're not talking big numbers here, we're talking about 2 or 3 cases a year of this type of injury. And for that reason, they can be difficult to diagnose. You really need to be on the ball in terms of knowing what you're looking for, knowing what's going on, and assessing the pelvic ring and the sacrum in its totality. There's a high chance of associated injury. These are high energy injuries, so there are other injuries that are more than likely to be happening at the same time. And with that goes the difficulty of ownership. Who takes these patients? Quite often, the initial injury will be seen, and ED will be trying to refer this patient to spine, to orthopedics, to neurosurgery, and generally the response from the middle grade is to run away. And it's very difficult in terms of getting ownership of these patients to manage them appropriately. So what's actually going on? So I think Nikhil will speak a bit more about this, but the sacrum is essentially the keystone of the spinopelvic junction, and it sits in and it provides that inherent stability to the spinopelvic junction, and allows for us to transmit the force from our upper body through to our legs. So it essentially enables us to carry our trunk and our skull around with us. What happens when we lose that connection is essentially we lose all that force transmission, and we lose the connections that are there that suddenly don't allow us to move. And so this is a very painful injury, and certainly not one that can sometimes be easy to mobilize on afterwards, because all those force vectors that travel through the spine and pelvis aren't in continuity anymore. A little bit about classification. Again, how useful classification systems are when you're dealing with cases that are so infrequent. You know, when we're seeing 2 or 3 cases a year and there are 4 classification types, are they going to be that relevant? I'm not entirely sure. But you can classify them as to their pattern. So we have the U-type, H-type, lambda or Y-type, and T-type that you can see, and that's a fairly easy classification to understand because it's just the shape of the fracture. And then the Roy Camille classification talks about type 1, type 2, and type 3. The type 1s being undisplaced, 2s, 2 and 3 essentially anterior and posterior displacement of the sacrum, and there is a type 4 where the sacral segment is particularly comminuted and lends itself to, or makes it more difficult to fix. And then there's the AO universal classification. There's again, AO classify everything. We're talking about sacral fractures, so that's the C classification of the spine. The C0 or C0 is the undisplaced sacral U variant. The C1 is that U-type variant without any posterior pelvic instability. The C2 is a bilateral complete injury. Now this again is a complete disconnection of the sacral segment to the pelvis, but you don't get the transverse pattern associated with it. Now this is probably something that Nicola or I would deal with much more than involving our spinal colleagues, because essentially we're trying to bolt the pelvis onto the spine again. But this is the one that the people in this room probably need to be more aware of and more associated with. This is the displaced U-type sacral fracture, and I'll probably just draw your attention to the bottom right segment of that, and that's when the sacrum is significantly displaced in the sagittal plane. And this is not something that lends itself to pure pelvic ring fixation, and that's something again we'll talk on, or I'm sure the next speakers will touch on. So in terms of emergencies, what emergencies are associated with this? Well, the 3 main categories are probably the life-threatening emergency, which is the hemodynamic type issue, the neurological issue, which is the more functional emergency, and the associated injuries, which can be manifold and varied. So in terms of the hemodynamic emergency, this is a picture of the venous plexus on the left and the arterial tree and some of the veins on the right. And the tubes and the red and blue tubes are things that I like to stay away from when I'm operating. They're not something that I'm particularly keen on going near, and certainly when they start leaking, that's a worrying thing for me. Now, unfortunately, around the sacrum, there are lots of red, blue, and sometimes yellow tubes. So I suspect the people in this room would be more comfortable with the yellow tubes, but I'm not a big fan of the yellow tubes either. But we've got all this to deal with, and you can see, just from the kind of injury that you're likely to get with a sacral fracture and the vertical fractures that are associated with this injury pattern, that if we put or transpose the pictures of the arteries and veins on top of that, they overlie pretty much exactly where the fractures are. The most common type of bleeding is from the sacral venous plexus. It's more prone to shearing, the walls of the veins are much more friable, and you can potentially get some fairly torrential bleeding from those areas. So how do we manage this? Well, the management of hemodynamic instability doesn't really change wherever the source might be. So we have to resuscitate, correct the blood loss, we have to diagnose that we're treating the right injury when we treat them, and we have to stabilize that blood flow. We have to stabilize the blood loss somehow. So the resuscitative phase, we've moved away a little bit from what some in the room may have done many years ago in terms of ATLS, and you walk into that room and you walk into your moulage sessions and you carry a bag of Ringer's lactate in each hand. What we tend to give now are blood and blood products. So you lose blood when you have major trauma, you give blood back. Most trauma centres, in fact most trauma units, will have massive transfusion protocols and major hemorrhage packs on site and ready to give very quickly. And usually the initial resuscitation phase is a 1-to-1-to-1 ratio of red blood cells, fresh frozen plasma, and platelets. And just a little rider on that, one unit of platelets is 4 packs of platelets in the UK. We tend to avoid the overuse of crystalloids if we can, and we tend to aim for permissive hypotension. So what we're trying to achieve is that the blood clot that initially forms stays in place, and we don't increase the blood pressure to try and disrupt that clot. It's very important to liaise with a haematologist, because once you start running out of that initial major transfusion pack, they have very fancy tests now, ROTEM and TEG tests, that can determine which factors you're missing and adjust the transfusion according to the missing factors. And then the one not to forget is tranexamic acid. I think the 1 gram bolus are now pretty much given every time pre-hospitally, but it's important not to forget the 2nd gram can be given over 24 hours, and I think this isn't just in trauma now. This is well proven concept that tranexamic acid can help with blood loss and reduce blood loss in anyone undergoing surgery. So in terms of the diagnosis, so ideally the trauma CTs are now performed within 30 minutes of arrival. They involve a contrast CT, and this allows us to assess where people might be bleeding from. And more importantly, you can diagnose other sources of bleeding. Now remember, these are high energy injuries, and so it is very likely that you will have areas that may not be directly involved with the pelvis that can be causing that bleeding. So into the chest cavity, into the abdominal cavity. The pelvic fracture or even the spinopelvic dissociation may be relatively easy to diagnose, and it's quite easy to label that as the source of bleeding without having to think too hard, because everyone knows that pelvic fractures cause blood loss and that can cause life-threatening injury. But actually sometimes it's the other injuries that are just as important and maybe causing that life-threatening bleeding. So how do we stabilize the bleeding? So in general, with pelvic fractures, we think of the pelvic binder as being a really useful life-saving tool. But in spinopelvic dissociation, I'm not entirely sure a binder will be that effective. You still generally will have an intact front of the ring. You may well have an intact symphysis, and so actually squeezing the pelvis together doesn't really help you too much. External fixation. Well, again, an external fixation will work if you get the 2 separate segments, put pins into them, and then connect them with a bar that doesn't move. So to do that, we have to connect pins into the spine and into the pelvis, and then connect those up. And again, I don't know of a system that works that way that you can do that. So there isn't an easy external fixator option to stabilize the thing. Traction, that's sometimes something that we use in pelvic surgery, and again, this may have a role, but the main role is just to tie a patient to a bed and stop them moving, and that allows everything to stabilize and the blood clots to form. I don't think there'll be any inherent stability associated with the traction, but if you have a patient that's particularly agitated, it might keep them in bed. Packing, potentially, if we can pack around the posterior aspects of the pelvis, that might be something that will help stem the flow of bleeding. Again, this is potentially not something that those in the room will be that familiar with, and usually, certainly at Preston, we have a protocol by which, if we are considering this, then possibly the vascular surgeons will be involved, because this is retroperitoneal packing, and it is packing all the way around to that sacral plexus, so it's technically quite demanding and challenging, and probably not something that we do routinely. And so finally, is definitive fixation, and that may be the only way that you can stabilize the ring in this situation. Now, I'd like to stress that this is, 1, a rare injury, and 2, a rare sequelae of that rare injury. So the last thing I would want is for everyone to go away and think everyone has a spinopelvic dissociation, needs to be stabilized immediately, but it may be the only way that you have to control bleeding, and that will be exceedingly rare. So the neurological emergencies. I'm not proposing that I stand in front of a room full of spinal surgeons and teach you about cauda equina, because I'm sure you know far more about it than I do. But it's fairly easy to see that that kind of injury might impinge upon the spinal canal and might cause that cauda equina. I will reassure you, though, that if you get in early and you are able to decompress and stabilize that segment, then actually the functional recovery is relatively good. And this is a paper back from 2006 suggesting that if you can decompress and stabilize that spinopelvic junction, there is actually relatively good chance of neurological recovery. Maybe not other bits, but certainly the neurological recovery is there. And this is where you guys all come in, because actually sometimes it can be quite difficult to convince people that this is an injury that needs intervention from the spinal side. But actually, if there is neurological compromise, it can be really helpful. And then associated injuries. So again, it comes back down to this is usually a high energy injury. And I put the paper on here, but it's not a very good paper, and I wouldn't recommend reading it for anything other than the table on the side. But what it does show is that there are a number of other injuries that are associated with it. And those are the kinds of things you'd expect with high energy type injuries: head injuries, thoracic injuries, abdominal injuries. And so the key point to take away from this is that actually there may be a lot of other specialties that are involved in the care of this patient. There are a lot of other people that you need to involve fairly early to be able to manage this patient adequately. So in summary, this is a fairly rare injury. It can cause an emergent neurological or vascular injury such that we may need to perform emergency interventions. It's worthwhile having a careful assessment of the clinical and radiological features to decide what those interventions might be. And again, I would recommend highly that you, rather than everyone run away from the problem, it's very useful to have a very early collegiate and multi-specialty input from the time the patient arrives. Thank you.
Questions at the end? We'll do the questions in the end.
Questions at the end?
Yeah.
Okay.
Thank you. Thank you.
Hi, good afternoon, everyone. It's always challenging to do talks in the first session after lunch. But anyway, here goes. It's always, it's nice to be invited to a spine conference once in a while. Like Sachin said, we have been upgraded significantly. So the remit of my talk is to try and cover the concepts of pelvic ring instability, which might be familiar to some of you, maybe not so familiar to others. To look at the role of the sacrum in pelvic ring instability and also in spinopelvic instability. Then to review some of the stabilization techniques of pelvic ring fractures, particularly those that are relevant to a spinopelvic dissociation. And then I've got a few case examples of cases that we have done over the years at Salford with Hassan and Rajat and my other spinal colleagues. So instability of the pelvic ring. We know that the pelvic ring is formed of the innominate bone on each side and the sacrum in the middle. On its own, the pelvis has no stability. But then you bring in all the ligaments of the symphysis pubis and the ligaments of the sacroiliac joint, and the pelvis becomes incredibly stable, which is quite difficult to break in young people without a significant amount of trauma. My approach to classification systems is that it should help me understand the injury and it should help me try and figure out the treatment. The simplest classification of pelvic ring injuries is the one described by myself, Mr. Shah, the good, the bad, and the ugly. But that's not very useful. The classification by Tile and Penol is quite useful. In type A, the pelvic ring is stable. So you might have a fracture that's unstable, but the ring is stable. In type B, your ring is rotationally unstable, which means it can open in one plane, but the tension band at the back is intact. And in a type C, the ring is completely unstable, all the ligaments are gone, and you get basically multi-directional instability of the pelvic ring. So classically, a type B, where the posterior tension band or the sacroiliac ligaments are intact, is what is called as the open book fracture, which I'm sure all of you have heard. And in a type C, all the ligaments are disrupted, the pelvis can move anywhere, and this is usually the most serious of all injuries. So this shows a type C pelvic injury. You can see the sacroiliac joint has opened up quite parallel joint surfaces, and it is unstable in the anterior posterior plane, craniocaudally, and rotational. So there are many lesions which can cause the ring to be unstable posteriorly. The one of relevance for this talk are the sacral fractures. But there are other pelvic ring injuries that can also lead to instability, and they include sacroiliac joint disruptions or iliac fractures and crescent fractures. So let's look at the role of the sacrum in this pelvic instability. Now, not only is the sacrum the keystone of the pelvic ring, but it is actually the base for the spinal column. So if you don't have a stable pelvis, it is very difficult to have a stable spine on top of it. And this is given to it by these various ligaments. If you get a vertical fracture of the sacrum on one side, you will probably get a pelvic ring that is unstable, but you may not get spinopelvic instability. And if you get an isolated transverse fracture of the sacrum below the level of the sacroiliac joint, you will probably get some axial instability, but the ring will probably be quite stable. And that's important to appreciate how these fractures affect ring stability. Now, this 3-zone classification system was useful in understanding the location of the fracture and the neurological risk. So obviously, zone 1 fractures in the ala have a low risk of causing neurological problems. A transforaminal fracture in the zone 2 has a higher risk, and the one in the midline, which can go into the canal, has the highest risk. Unfortunately, this classification does not recognize combination fracture lines or multiplanar fracture lines. The Roy-Camille classification describes how this moves in an axial plane. So your sacral body can be angulated or translated or compressed. But again, it has limitations because it does not describe or include the vertical fracture lines that typically lead to a spinopelvic dissociation. And finally, the Isler classification or the Euler classification, I'm not sure how you guys say it nowadays, but if the fracture line of the sacrum exits lateral to the L5-S1 facet, it's quite likely that your lumbosacral stability is not affected, even though the pelvic ring might be unstable. And as we go medially, either through the facet joint or midline, it's more and more likely that you will get lumbopelvic instability. Particularly if you get bilateral type C fractures, that's the classical H-shaped fracture that will cause spinopelvic instability. Now let's look at some of the stabilization techniques of what we do when we get an unstable pelvic ring. These can be open or percutaneous, and they can be done in the supine or in the prone position. So in any injury combination, we can generally work around what the spine surgeon wants to do. We can fix it prone, supine, and whatever you let us do, we can generally get on with it and stabilize the pelvic ring quite stably. Obviously, when you get such a bad Morel-Laval lesion, you want to try and avoid major open dissection because it's going to cause skin breakdown and infection. So these are cases where closed reductions and percutaneous fixations are much better. But sometimes your closed reductions don't work, or the patient comes after a delay, or you get a lumbopelvic dissociation, or you have to decompress sacral nerve roots. And in these cases, an open reduction of the sacrum becomes mandatory. Why should we fix a sacrum at all if it's displaced and causing instability? Because if we don't, we can get chronic pain, chronic disability, sitting imbalance, sleeping imbalance, malunion, malalignment, leg length problems, and sometimes late neurological dysfunction as well. So this is a classic type C pelvic injury, the good, the bad, and the ugly. This is the ugly one. Oh, by the way, if you're interested, Clint Eastwood was my spiritual guru. So in this case, you have a wide separation of the symphysis pubis, and you have a sacral fracture. The ring is unstable in all planes. And what I used to do before percutaneous techniques became mainstream is to do these bilateral incisions on the side of the sacroiliac joint, and you thread a plate across in a subfacial plane at the back of the sacrum and make it work like a posterior tension band plate or the transiliac plating. It's an incredibly good and useful technique, and it really gives you a very stable pelvic ring. And in the front, you stabilize it with 2 plates around the symphysis pubis. And that's your ring sorted. You've fixed the anterior ring lesion and you've fixed the posterior ring lesion. There are some other techniques to put sacral plates on which are described in the books. And I have to say they're probably only described in the books. I've never had to do them, and I've not seen anyone do these things. But nowadays in modern pelvic surgery, probably the iliosacral screw is the most commonly used technique. It can be done percutaneously so long as you can get these safe corridors. So the fracture has to be reduced or reducible before you can put a percutaneous screw in. So this shows a typical sacral fracture without much displacement as part of a pelvic ring injury. And in the back, we have fixed it with 2 SI screws, and in the front using a supraacetabular X-fix and a nicely healed ring once the implants are removed. You can use fully threaded screws if you want to avoid over-compression of a comminuted sacrum, because that can cause damage to the nerve roots. And you can use a long screw going from one end of the to the other end, or what the Americans like to call the home run screw, if you get bilateral sacral fractures. This is another technique which is very useful for sacroiliac joint disruptions. It is done through an anterior approach, similar to what you take for a bone graft from the iliac crest. We call it the first window of an ilioinguinal exposure. And you put 2 plates on the sacroiliac joint from the front and a double plating of the symphysis to get the ring to become stable again. This is another variation of a crescent fracture where you get a fracture of the iliac bone going into the sacroiliac joint. As you can see, this is a type C injury. This came after a lot of delay, so you can't really restore the anatomy of the pelvic ring perfectly after the first 10-15 days. And this has been fixed with plates for the present fracture and with an external fixator. Now, despite a deformed pelvic ring, this patient actually got very good function. Posterior transiliac infixes are now the vogue, and if you can get these 2 long iliac screws from the PSIS to the AIIS, you can put a posterior infix. Now let's look at sacral fractures and how they affect the spinopelvic dissociations. And this is where you get the typical H-shaped sacral fracture, transforaminal on each side, and you get transverse components. So what happens is, the upper part of the sacrum stays with the spine, and that can undergo flexion and rotation so that you lose the connection between the spine and the 2 sacral wings. So your sacrum can get a hyperkyphotic deformity. Morphologically, you can have an H or a U or a lambda or a T, or you can make up alphabets as the fracture lines go. And this is what causes typically a lumbopelvic instability, where you get spondylotosis of the top of the sacrum on the bottom of the sacrum with angulation, displacement, and significant neurological injury. Thankfully, it is a rare injury. Unfortunately, it has a high rate of neurological complications. The treatment principles revolve around restoring the connection between the lumbar spine and the pelvis, and to get stable fixation so that you can get the patient mobilized and try and get reasonably good outcomes. Closed reductions have been described in these cases. I think the London group has described a technique for closed reduction in prone position. I've never done it, but my colleagues in London tell me that it does work when you do it early and you do it correctly. So there are 2 philosophies of fixing a sacral fracture. Now, I think before I fully understood spinopelvic dissociations, I'm sure that I have fixed several injuries purely by fixing the pelvic ring and getting sufficient stability. But in modern orthopedics, if you see spinopelvic dissociations, people go for triangular fixations. From the data that is available, comparing the 2 techniques, to the best of my knowledge, there is no functional difference at 2 years and 5 years, whichever philosophy you use. So this is what is meant by the triangular fixation, where you fix a ring in a horizontal plane, and then you attach the spine to the pelvis, putting these long screws from the PSIS to the AIIS. And generally, these are done in complex instabilities that are not amenable purely to a traditional ring fixation in the horizontal plane. Biomechanically, it is much stronger because it gives you good alignment of the ilium, the sacrum, and the lumbar spine, which is stable enough to counter all these forces. It can transfer the load directly to the lumbar spine, bypassing the area in the center and stopping the flexion of the pelvis. And at the same time, it can stabilize the pelvic ring. I remember the first case that I think I did with Rajat several years ago, and when he put those interconnecting rods at the back, basically what it did is it stabilized my posterior pelvic ring, and I did not really have to do anything. And that came as a big learning point for me, that with your spinopelvic fixations, you can actually stabilize the pelvic ring as well. So in some sacral fractures, where you get extensively comminuted, vertically unstable sacral fractures, you might want to think of doing a spinopelvic fixation instead of just a ring fixation. For delayed fractures, for non-unions also, it can be quite useful. And nowadays, for the elderly population where you get instability because of insufficiency fractures, this technique is quite useful. So these are some cases that we have done together at Salford. You can see on this side, you get an obvious spinopelvic dissociation. There is a very comminuted fracture on the left side of the sacrum with neurological deficit. That's your MRI scans. I haven't got a faintest of clue what that means, but Hassan always asks for an MRI scan when I call him, so that's what it looks like. And then that's the fixation. You've got your spinopelvic fixation, and then you fix the posterior ring lesion with a long screw, iliosacrally, and the anterior ring lesion with an anterior infix to get a reasonably good bony alignment and a reasonably good outcome at about 6 months after surgery. Another case, this is an H-shaped fracture. There's a sacral fracture on each side and an obvious spinopelvic dissociation. You can see how badly hyperkyphotic that sacral fracture is. And this patient also had a very significant neurological injury. In this case, the pelvic ring was actually stable, and all you had to do was address the sacrum. So we have done a classic triangular fixation with a long iliosacral screw and a lumbopelvic stabilization. There is no need in this case to do any anterior ring fixation. And again, this has given quite a good outcome for the patient. I shall leave you to debate the role of spinal decompression because the literature seems to be divided. The result seems to be very similar whether you decompress it or not, and whether you do an indirect or direct decompression. The outcomes, unfortunately, despite good treatment, remain suboptimal. And often the determinant of the outcome is not just the bony injury, but the soft tissue problems, the urological and the sexual dysfunction, the neurological issues, and the kyphotic angle of the sacrum. And often if these are very severe injuries, and it is these factors that determine the long-term outcome of these patients. So to summarize, these are complex injury patterns. I think it's important for us to understand the role of the sacrum. It is the gray zone. It is in no man's land. You get a referral to the spinal surgeon with a sacrum fracture, send it to the pelvic guys. And the pelvic guys, no, send it to the spinal guys. But this is something that needs teamwork. You need to work together with your spine and pelvic colleagues and discuss these cases and then address them together as a good team. And I think we have a good team where we handle these fractures both in Preston and in Salford. So thank you very much. I don't think this work would have been possible without my pelvic and spinal colleagues around Greater Manchester. Thanks a lot.
That's not my talk. Great, good afternoon everyone. So I'm a consultant spine surgeon at the Royal London. And yeah, like you said, spinopelvic dissociation is all part of a team of pelvic and trauma surgeons. We actually see probably double most people, so we probably have about 6 or 7 a year. So it's not rare in our hospital, but I guess on the grand scheme of things, it's very uncommon. So there will be a little bit of repetition, but there is a point to the repetition when I give it. So brief recap, a spinal perspective on the aspects of that we think of, and our experience and how it relates to the literature. So first described in 1969, and I was interested, the first talk talked about lumbopelvic dissociation. I think that's the title of this session now, because it was first referred to as jumper's fracture, and then later on we talk about spinopelvic dissociation, then there's lumbar pelvic dissociation. So the result of that is when you go into the literature, you've actually got to search about 2 or 3 different things, because when you look up one thing, it doesn't actually bring up all the results you want it to, and actually jumper's fracture on top of that actually gives you a few more results. So that's the first thing where it kind of catches you out if you're looking for the detail, but essentially it's a fracture in simple terms of the lumbar spine, including that superior aspect of the sacrum. And as mentioned, there are different types of that. It's a high energy trauma, as said. A lot of it is fall from a height. There's a reason why it was called jumpers or suicide jumpers fracture, because that's probably the biggest cohort of patients in America, with more and more airborne sports like whatever, skydiving, whatever, they're having an increase in that kind of population. Now, this is the thing. So neurological impairment, there are some studies that are showing 90, 95%. It goes 40 to 90%, with cauda equina up to 44%. If you think about that, and think how topical cauda equina syndrome is now, and look at some of the data that I'm going to show, it's actually something that we need to pay a bit more attention to. So the key here for me is clinical examination. So here's a patient that comes in, he's got all sorts of other injuries, lower limb, fractures, calcaneal, maybe a splenic laceration. They do all the trauma series, they shove a catheter in, and the patient might be tubed or not tubed, but somehow or the other, someone's missed the fact that this patient has cauda equina syndrome. And so the delayed presentation then becomes a common feature. If you were referred a disc prolapse that had cauda equina and was referred to at 3-4 days, everyone would be up in arms as a first referral. But there's a very common theme that comes out of spinopelvic dissociation, which is delayed cauda equina syndrome. So it's really important to examine the patients. And we had one recently where the patient only on day 7, when a consultant did a ward round, they have consultant weeks of ward rounds, that he realized that while the patient was waiting for transfers, actually the patient had cauda equina syndrome all along. And the only other thing I would say about radiology is fine cut CT. So we do 1.25 millimeter slices at the Royal London. We find it's more accurate and helps us with our surgical planning. We've talked about the demographics already. So it's generally young population. It's already been mentioned that it's increasingly, we're seeing it in osteoporotic fractures. Sometimes that is delayed. So here's the key thing for me. When we looked at we're updating our database, we're up to about 2021 or so. The time to surgery from injury was 5.7 days. And I've already mentioned that neurological injury can be up to 90%, cauda equina up to 40%. And here we are with an average surgical time of 5.7 days, which I thought was awful. Then you look at whatever meta-analyses are on, the best ones are quite consistent from 10 years ago, from 3 years ago, that it's around 8.7 days when you look at it. Why is that? Well, some of them end up in ITU, some of them are in different hospitals, some of them have distracting injuries, sometimes it's missed. So it's something that we need to pay a little bit more attention to. And they do have, here's a page example of some of our database, and they can have upper limb injuries, lower limb injuries, calcaneal fractures, obviously quite common. Some of them have abdominal surgery. A lot of them are going to ITU. So there are a lot of things you're dealing with. On top of what you have to deal with a normal cauda equina pathway, you have all these mitigating injuries that you have to deal with. And like I said, in our center, we're seeing, I'd say 6 to 8 a year. Once every 6 to 8 weeks, I say we see one. So it's not uncommon. We have a protocol, we have a way we do it, and so we've got used to it. Now, we've talked about the classification. So the importance from a spinal perspective here is that if you look at the Roy-Camille classification on the bottom, is that you'll see there's a change in the pelvic parameters. So sagittal balance has been altered. Now, so therefore our responsibility to try and restore sagittal balance. If you want to restore sagittal balance, the key time to do that is in the first 3 or 4 days, because the sacrum has a large surface area, cancellous bone. When you get in between days 1 to 4 and you try and reduce it, which I'll show in a second, the results have been good for us for closed reduction. Once you get to day 4 or 5, it starts getting quite sticky. Day 7, forget about it. So we have to think as spinal surgeons about this aspect of sagittal balance and long-term pain and deformity. So it does become quite important then to the patients to try and get them across sooner. So here's the U and H type, as you've seen, are the most common injuries. So the pelvic guys obviously focus on what is the coronal axial there. We like to focus on the sagittal. It always happens when we look at a scan, and at the same time we say, can we see the sagittal? At the same time they say, can we see the coronal? I'm looking at the kyphosis, I'm looking at the change in pelvic parameters. These are the things that come to my mind, as well as the neural compression that you're getting from the spinal canal. H shape is just an extension further down the sacrum. That's just something to bear in mind when you're dealing with it. So here's the crux of it. So first of all, do they need surgery or not? The white aspects there are less controversial. Reduction, do you do it open or closed? That's slightly controversial. Do you do it open or percutaneous from a spinal point of view, and also from a pelvic point of view? And what about the configuration of the fixation? So I think this is less controversial for a spinopelvic injury unless the patient does not tolerate surgery or they're not going to be weight bearing for 2 to 3 months, and I'd argue that they still potentially need it because A, for pain, and B, if there's a deformity, you want to try and correct it, spinal orthopedic perspective of everything. But otherwise, surgery is indicated. I think most people would agree on that. So open versus closed reduction, here's where it's interesting. As you look at the literature, 61.2% of people get an open reduction. Ours is about 24%, so much less. And about 47.6 people get an open decompression in the literature. Ours is about 20% again, and I'd say most of that is because we do a closed reduction, and so an indirect decompression, unless there are obvious fragments that we can see which are inside the spinal canal. It does have its pitfalls. You open it up and there are nerve roots everywhere. They're wrapped around the lamina, they're stuck to the side of the bone, the other bone, and you're often picking nerve roots off everywhere and unwrapping it from different places. It can be pretty unrewarding. But like you said, surprising neurological recovery sometimes. I remember one case where I literally only saw one strand that was still going down. And he was a young 20-odd-year-old, and yet 2 years later, this guy, his erection came back. He got sexual function back, and I swear to God, literally all the strands looked as if they were floating or ruptured, and there was one strand I saw going through past the fracture line. So I'd say our reason for a low open decompression rate is because of the technique of closed reduction. And this is the key here, I think, is getting it reduced in a timely fashion. If someone has multiple injuries and they don't end up in ITU, then I think they're the ones that end up getting done quicker because they come to a major trauma center. We list them within the first few days. They hopefully get done within those few days. The ones that go to ITU may end up waiting longer. Maybe they've had abdominal surgery or life-saving surgery, or they're unstable or whatever. The ones that are transferred get delayed as well. So those last two, I think, are the reasons why the data is kind of skewed a bit in terms of the average wait time for surgery. But the problem is, I think once you get to day 4, the closed reduction becomes much harder and sometimes impossible, in which case you have to open it and start using osteotomes around nerve roots and things, which has its own issues. So this is what we do. I won't take credit for making this up. This was Pete Bates, one of my pelvic colleagues, when he came back from Dallas. We started doing this together and then started converting it about 10 years ago from open to percutaneous fixation. So the patient's prone, and it's interesting, Mr. Shah said that he doesn't mind supine prone. What I found with our guys is because they don't do as much prone surgery, when we turn the patient prone, we say, no, it has to be prone because we're putting perc screws in. The x-ray, all your x-rays are the opposite, aren't they? So you have to angle your x-rays the opposite to what you're used to. So sometimes it can be confusing because you have your inlet, your outlet, your this view, all the other views they do. When you turn a patient prone, it's the opposite way, isn't it? So sometimes that can be a bit confusing for everyone. But essentially, one person weighing down on where the sacrum is, another person extending the legs up, and pretty simple maneuver. You flex the knees, you lift it up, you push down, and within the first 3 days, I'd say about 75% of them reduce, which may account for why we have lower kind of open decompression rates. And that's the point, restore anatomy, so that's an intraoperative closed reduction, no incisions been made there, and it's something actually we've repeated on quite a number of occasions. So the surgery himself, so back when they first kind of coined this, there were all sorts of things being done, hooks, sacral block resection, you name it, anything that was out there. But the method of choice now is, as mentioned, triangular fixation. And biomechanically, there are cadaveric studies that show that it is superior to an SI screw on its own, the smaller displacement on the greater load, higher rotational stability, and ability to maintain and help correct akyphosis as well. Longer-term functional outcomes, well, actually, funny enough, that's the next thing we're now looking at. We don't have that at present, but we're looking at that now. But triangular fixation is the treatment of choice. And the only failures we had early on was when there was a dysplastic sacrum. We had no navigation at that point because we convinced our pelvic guys to use a bit of navigation. And they didn't put an SI screw in. I was still putting only screws in from L5 to the pelvis. And those, actually 2 of the 3 I did like that failed. So I learned that actually if there's no SI screw, you have to extend up to L4, or if the bone quality is not particularly good. But otherwise, L5 to the pelvis suited us. So that's the classic triangular fixation. Do you do the spine or the pelvis first? You can do either. We started off doing the spine first, and then the pelvic guys kept complaining that, we were making their track difficult. They couldn't get the screw in, so they ended up putting their screw in first, and now we do it second. But I don't think it matters which way around you do it. So what about perc versus open? This is just general data for spinal fractures. We know that for trauma, there are a lot of benefits for it in terms of pain, mobility, blood loss, infection. And certainly for me, at the Royal London, it transformed what started off being a 2.5 hour operation on average to something that's now 45 minutes. So naturally, we decided to transfer this to percutaneous. The incisions for an open lumbosacral fusion can be massive. And so mobilization, infection, blood loss, recovery, all those things, as we know, become affected. So these are the classic incisions. That's the picture we used for the first paper we published on this back around 7 years ago. That's obviously the spinal one. Our pelvic guys do an incision in, lateral on the thigh, and that's it for, a really significant high trauma injury. You're left with 4 incisions of that size. If there are SI screws in, and you're happy with the bone quality, we mobilize them straight away. No SI screw, no immediate mobilization. We just get them up gently. And anyway, if there's no SI screw, we go up to L4. And the key here is trying to restore that sagittal alignment and neural decompression and mobilization. So actually really basic orthopedic principles. The X-ray is another thing. It helps when you have a radiographer that is familiar with all the pelvic angles, otherwise it becomes quite difficult. They have all their different X-rays they do. Right at the beginning, the pelvic guys used to help us with the X-rays, so when we were determining where we put our pelvic screws, because they have to put an SI screw, they would often be holding the X-ray machine with the radiographer, telling them which way to point it. So that really helped, but obviously increased radiation has its own issues. And we've convinced the pelvic guys to use a bit of navigation when there's a difficult pelvis. And we're getting the 7D technology soon. So that's going to be the next thing to see how that will influence our kind of radiological outcomes. So in terms of neurological recovery, I'd say it's excellent if you get there on time. Obviously, if you get to a quarter equina syndrome on day 7, then you can't expect amazing results. But actually, about 2/3 of them, even with that delay at 5.7 days where we are, have about a 65% improvement. But you can see that 34% of people still have quarter equina syndrome. Post-surgery is an amazing high number, but because it's uncommon stroke rare issue, it's not something that's particularly talked about. There is a relatively high complication rate. So at 29.9%, we're slightly low. I have to say, when I saw our initial complication rate, I thought that was quite high, but it's slightly low in the literature. If you look at the spinal complication rate for spinal fixations, this is actually much lower. And I think this just reflects the intensity of the injury and the fact that a lot of them are in ITU. And of course, with that comes a higher infection rate. I thought our infection rate of 20% was astronomically high, but actually in the literature, it's even higher. So in summary, this is a high NG trauma, high neurological injury rate. The ideal is for an early close reduction. Most we find can be done percutaneously, and early mobilization is the key for us. So we're now looking at our longer term outcomes, and we're going to look at the effect of what navigation or 7D can have on this. But I guess the bigger question here is both for reduction in terms of sagittal alignment and even more importantly for neurological recovery, how do we get these patients to us quicker? And, we've seen how difficult it is with normal cortical equina syndrome, and this has all the mitigating factors. So some challenges ahead for this.
Any questions, please? Rajat?
Thank you very much. Challenging topic and fantastic presentations. I just wanted to clarify from the panel, essentially, we put all these screws in, especially from the spinal perspective. We're putting the screws, pedicle screws into across the L5-S1 junction and essentially stopping it from moving. I mean, do you routinely take all the metalwork out, especially for younger patients?
Yeah, it's a really good question. I have a really nice poster in the main auditorium on whether one removes screws for for percutaneous stabilization. So I'll be really honest with you. About 10 years ago, or 11 years ago, when I first started doing this, there was no space to, if you're fixing 4 to 8 fractures a week, and these as well, we'd have to make a whole list every week, a one-day list to take out fracture fixation metalwork. So we didn't do it. And now we've looked at the longer-term data on this, and actually very, very few of them, I can't remember the exact figure, Jack can tell you who's here, very, very few of them ended up having an issue with them. Now, with the pelvic bolts, it's slightly different. They do get a bit irritable, and we may have to take them out, but generally, we've basically left it in.
Yeah, but I think the long-term results are actually not actually long-term, I don't think, because you need at least 20, 25, 30-year follow-ups to know what stopping the movement L5-S1 is doing to these patients. Because we need to know what happens to the adjacent levels in 2 decades, 3 decades, because these are young patients, some of them.
Yeah. No, we don't. That's actually what we're looking at now. Yeah.
Thank you.
Good afternoon. You might have already addressed my question, but in fact I've got 2 questions. The first question is, in the setting of traumatic cortical equina syndrome, does it really make a difference whether you intervene today or tomorrow or in a week's time? And the second question is...
Can you speak up a bit? We can't hear you very well, please.
Sorry.
You said something about traumatic spinal
Yeah, so in
cortical
the setting
equina.
of traumatic cortical equina syndrome in these kind of cases, does it make a difference when you intervene? Does it make a difference whether you intervene, for example, on the day of admissions or even like a week later? Because by the sound of it, a lot of the nerves will be injured. And my second question is that these type of injuries are associated with high rates of moral level lesions. How do you manage these?
So I think the first question was about, was there a difference between decompressing cortical equina
Timing.
early or late? Yeah, so because the numbers are low, evidence is not great. But actually, if you, Jens Chapman, I had a conversation with Jens Chapman about this exact topic, and I think one of you showed his paper from 2006, that they consistently, at Harbour View, they consistently got patients in, within a 3.7-day period, and their neurological recovery rate was 86%, which is higher than the literature, higher than ours. So I'd say the answer to that question is yes.
Yeah, so just on that, that paper that I put up from Chip Rout's unit as a pelvic surgeon, they would operate very early. So I think there is something in operating early, and I think a lot of the literature that we see published is based around late operation, and that may be skewing the results a little bit.
My second point about moral level lesions, how do you manage these?
Sorry?
Moral level lesions.
Moral lesions, okay. They're talking about the skin.
Sorry, what was the question on morale level?
How do you ignore them, or do you intervene early? Because they can be associated with infections and sometimes even wound failures.
Yeah, I mean it's a problem, isn't it? It's a soft tissue injury. It can be a big degloving injury. I think you have to do what you need to do to treat the life-threatening, the limb-threatening injuries, and then get your plastic surgical colleagues involved quite early to help you with the soft tissue aspect. If there's a cortical equina or something like that, you're going to let the soft tissue aspect stop you from dealing with that. I'd say you probably deal with the emergency stuff and then let the plastics deal with morale level if they need to.
Yeah, so I think the literature treatment of moral level lesions is quite controversial, and the opinion is furiously divided between leave them alone to aggressively excise them and put a flap on it. So our philosophy, certainly in the Northwest Pelvic Unit now for almost 20 years, has been to go on the conservative side and let it heal so long as you don't need access to the fracture through that lesion. So if you can avoid that, and if you don't need to use that skin, and if you can use an alternative technique to fix the fracture, we tend to leave it alone, and almost always it settles down. You have to watch it closely for infection. Some of them get left with a boggy, redundant swelling for life, which never goes away, but it seems to be fine. In very rare cases where you have to use that part of the skin to make your incision, you need help from the plastic surgeon to radically and aggressively debride it, do your fixation, and then do early soft tissue coverage. But those cases are thankfully few.
You've got a couple of minutes, so I think you were up first. Go on.
Can I ask two questions, please? So the first question is about...
Can you speak up a bit, please?
So can I please ask two questions? So the first question is about the H-shaped fractures. So a few of the recent ones I've encountered, they've got quite significant superior migration, and also rotationally, they kind of opened up. So if I've got a patient on table, do you have any tips or tricks to try to reduce that? I saw a photo about traction on table. We've tried that before, but just quite difficult to control the rotation still. I guess
H-type fractures, rotation.
Sacral fractures.
Yeah, H-type fractures.
H-type, yeah. So if you see on the first day that you have a type C pelvic injury, and if you know that you're not going to be able to get in early because of ICU problems, head injuries, and other things, then I recommend skeletal traction with good muscle relaxation. And without a shadow of doubt, whether you like it or not, it does make a difference in bringing it down over 3, 4, 5 days, and makes it good enough that during surgery, you can use shank screws as joysticks to try and complete the remaining reduction maneuver. If you don't use skeletal traction in the early days, and if it gets fixed like that for 6, 7 days, then usually it's a nightmare. You can't bring it down. And I showed one patient where I only got to her at 3 weeks, and I wasn't able to correct it.
What if I get to her within the first day, which was my last patient? Does
Sorry?
that happen? So I got to my last patient with the H-shaped fracture on day 0, and she was quite superior migrated. So what do you do then if it's fresh?
So if it's fresh and on the table and you're going in early, if you have access to a pelvic table, you set your patient up on a pelvic table with the appropriate skeletal tractions. You can use shank screws in the opposite side of the pelvis to stabilize the patient, and you can gradually crank it down. If you're supine, you can flex the hip and crank it upwards. So there are maneuvers that you can do of closed reduction on a pelvic table. The other thing is if you have a star frame, you can actually bolt it to the pelvis and use a star frame to reduce it closed as well. So we have that as well.
I'm sorry, I've draw this session to a close. It's 3:30, which is interest of time. I'm really sorry. Right, so I'd like to thank the speakers. Just one second.